First of all, we just want to apologise. Nicole French, who is our exercise physiologist, can't be here with us today, so Clare, who's the dietitian, is going to just present on Nicole's little section. So basically we just put together a presentation on something that we're doing at the moment, and it's been successful in general practice. So basically what we've done is set up a diabetes clinic that we're now about to commence rolling out into the third general practice. So in our diabetes clinic, the main players, I suppose you could say, would be the GP, the practice nurse, myself, the exercise physiologist, and the dietitian. So basically we've just mentioned the roles of what people do, and you guys probably know this already, but we'll just recap. So the GP is there to monitor and make changes to medication basically as required. My role is to attend to the care plan. I download the BGL results, make referrals to the allied health, educate and provide the patient with support. The dietitian is there to assist with diet modifications and motivation, and the exercise physiologist is there for motivational interviewing and the exercise program. So collaboratively we've managed to work together to reduce HbA1c levels, and obviously that's for better health outcomes and prevention of complications in our patients. So as we can see, our role as practice nurses has changed. So once we, as you saw on the slide before, we used to probably be known more to be the nurses that run around giving needles and attend to dressings and doing those sort of things, whereas nowadays we tend to do a lot more preventative care, and we do a lot of management, and particularly chronic disease, which we see a lot of in general practice. So that's a little picture of myself and the receptionist at one of our clinics that we used to work at. And obviously, as I've been in general practice for 12 years now, I've seen many changes come across, and our role changing definitely into a more sort of admin type role, I suppose you could say. So primarily we used to do a lot of venipuncture, wound care, immunisations, infection control, and of course assist with reception, making appointments, patient bookings, that sort of thing. So in the modern, or in today, I suppose, as a practice nurse myself, I do a lot of care plans, I do a lot of health assessments, I look at the diabetes cycle of care and I complete that. We are, like I said, we've established and opened 3 diabetes clinics. A lot of time is spent educating the patient on diabetes and motivating. So basically we get the patients to come back and see me on a fortnightly or monthly basis, depending on their BGL levels and how their monitoring is going. And then through the care plan, we run them through to the allied health. So basically what we do is we initially start with running the diabetes clinic with a new patient. We get them to come in and we can charge an item 23, so they obviously see the GP and then they see me as a practice nurse, and we can charge a 109.97. And this is making sure, of course, that their care plan's already in place. So if their care plan hasn't been put in place yet, you're unable to charge these or bill them for these numbers. But once the care plan has been done, you can do that. So the patient will attend the following week after their education of the BGL machine for a download. And we use basically so this is an AccuCheck, which is supplied by Roche. So this is what they see when they come in for their first download. I don't know if many people are familiar or use this in general practice now at all. Yes, no, yes, yep. So I find this really useful because, especially with people that can't speak English really well, they can actually see where their BGLs are lying. And as we can see there on that example, the green is the area, so that's between 4 and 8 where their BGLs have to sit. So often for these people, if you can actually say to them, well, your sugar levels need to sit in this area, and start pointing out just some basic numbers, they understand that really well. So this is a visual tool for us, has been really useful, really handy. So basically, after the patient will see me, they'll see the GP, and the GP may go through what I've said. And what we try and do is we actually try and get them in to see the dietitian and the exercise physiologist on the same day, so that we have basically a one-stop shop happening. So the patient may have 4 appointments on the one day, but they love it, and it's convenient because they come in and it's basically bang, bang, bang. So the feedback we've had has been really positive. So in the last 6 months that we've been working together, we have seen HbA1c results drop in about 85% of our patients. And this is just obviously through us looking at those handouts, checking HbA1c levels, that sort of thing. And I suppose together we have classed ourselves as the peas in the pod. Is that right? So again, regular and close monitoring of the BGL results, and consulting on the same day consecutively. So this point is, if anything, in the whole presentation is something I want to try and get across to you guys as much as, really strongly and as much as possible, because the convenience for the patient is just, they just love it. It's amazing. They don't have to come backwards and forwards, or they don't have to go and see another allied at another clinic. So this has been really, really successful. So obviously enthusiastic, happy and positive discussions, even when the results are poor. So even if their results haven't been great, I still try and say to them, well done, because at least you've been able to take some readings. And a lot of the times, this is the first time the patient's ever had to take their BGL. So even if you don't have 3 or 4 days consecutively and they haven't done 3 readings a day, the fact that they've come back to you is a really positive step. We also tell the patients that we together have meetings, so we'll have a little team meeting, or sometimes we might consult. So I might buzz Clare and say, Clare, I need you to come in, can you give me a hand with this? And again, the patients really enjoy that, and they feel that they're really being listened to and that we're working together as a team. I'll just hand over to Clare now.
Okay, so I'm Clare and I'm the dietitian. I'm also going to be here speaking on Nicole, the EP's behalf. So I just wanted to go through a little bit about the role of allied health in this diabetes clinic. So like Lisa mentioned, the patient will see the GP, they'll get their blood sugar levels downloaded, but then allied health will then go and help the patient understand what they have to do next to manage their condition. So their sugar levels might be quite high, they might be very erratic, so how can we assist with improving those sugar levels, not just from a medication perspective, but from diet and exercise as well. So we know that the keys to diabetes management, apart from medication, can also be achieving and maintaining a healthy weight. So to do that, I'm involved, as well as the exercise physiologist, in helping to achieve that. Eating a healthy and balanced diet, which is predominantly my role in the diabetes clinic, and then getting the patients to begin exercising. So what I found is that about 80 to 90% of my patients will be overweight, don't exercise, and have a very poor understanding of nutrition and their condition. Okay, so my role is then to step in and help them understand what nutrition has to do with diabetes. So first of all, after they've seen Lisa and the GP, patients will then come in to me, and I receive the patient background provided by Lisa previously, and the blood sugar download. So then I can see how well the patient's already going at controlling their sugar levels, and at this stage most of them aren't very good. So this is when I tend to step in and take a measurement of their height, their weight, as well as their waist circumference and their BMI. So that way we can also track progress over the sessions through the clinic as to how the patient is going. I then conduct a nutrition assessment which focuses on eating habits. So not necessarily specific things that they are eating, but their habits. So whether they're having regular meals, what those meals consist of, whether they're large, small portions, and specifically though focusing on their carbohydrate intake. And overall energy to watch their weight. Okay, so once this is done, the education comes in play. So my role is to essentially provide patients with the skills to manage their condition. So the first thing that I would focus on would be their carbohydrate intake, and explaining to patients basically what is a carbohydrate. So most practice nurses or GPs may have limited time in actually educating patients on what is a carbohydrate. Now that they have diabetes, what do they do? What sort of food do they have to watch? Whereas now they get to spend at least half an hour with myself to go through this. And a lot of patients don't even know what a carbohydrate is. They just say, I was told not to eat bread and pasta, and I've cut out bread and I've cut out pasta. But they don't really understand why. And a lot of other carbohydrate-containing foods, so things like fruits and milk and yogurt and legumes and lentils and potatoes and corn. So it's really about educating the patient on these things as well, not just not telling them what they can and can't eat, but providing education really. And then why these carbohydrate foods are important in managing their diabetes. Essentially, anytime they have a carbohydrate food, that will affect their blood sugar levels. So teaching them the role in carbohydrates in managing their condition. So also educating, like I mentioned, the difference between low GI and high GI. Do many of you guys spend time educating patients on this? Yep. So just educating the patient on what the difference is and why they should be choosing low GI. And also carbohydrate counting. So even for type 1 diabetic patients, not necessarily type 2, but type 2 that may have progressed to taking insulin, my role is to help teach them carbohydrate counting. Has many of you heard of that? Yeah. Yep. So just educating them on how much they should be eating for their units of insulin, but also working with the GP to ensure that the patients aren't necessarily eating to match their insulin regime, but that their insulin regime matches their current habits. A lot of people find that they're eating because they're scared to have a hypo, or they're eating more because they are injecting so many units, and they go by that regime that they've been told by their doctor. But if we're going to try and get them to lose some weight, we essentially want them to be eating a little bit less. So I find that being at the clinic with Lisa and the GP and the EP all on the same day with that patient there, we can work together to actually ensure that this insulin regime is matching more of their eating habits. And by me spending time with the patient to understand their eating habits, we can then hopefully see better outcomes. So once I've gone through carbohydrates, we then go through in consecutive sessions, not on the same day, dietary fats, focusing on portion size of foods, reading food labels, healthy main meals and snacks, identifying barriers and goal setting as well. So a lot of patients may not necessarily be motivated to change, but working with them to see what their goals are and what they want out of the actual sessions as well. And the last point, which would be most important, would be actually providing ongoing feedback to members of the team. So Lisa, the EP and the GP, and actually being there on the same day. I found that, I work in some clinics where I wasn't necessarily in the clinic seeing that specific doctor's patients on the day, but actually being there, being able to speak to the whole team, you can see the patients actually find it a lot more comforting as well, knowing that we're all there sort of supporting them. So the outcomes that I've seen through working together as our diabetes clinics, that the patients are more confident and understanding of their condition. Their understanding of what foods actually affect their blood sugar levels and why. Understanding of what foods impact on their sort of hearts, kidneys and other major organs, so why dietary fats are important. Watching their salt intake as well on their kidneys, so managing that as well. And understanding of what foods will actually impact their overall weight. And essentially learning how to maintain healthy eating habits and achieve their goals. So now I'm just going to present a little bit about the EP's role on behalf of Nicole. So she will get similar details to myself, so we get a patient background, she'll do an anthropometric assessment so we can have baseline testing. We then go through the exercise risk assessment, current or past physical activity habits, and she focuses on reducing sedentary behaviour, increasing incidental activity, and establishing healthy and sustainable exercise regimes. So most of the patients we do see are overweight, and some of them obese and morbidly obese, so ensuring that when they are exercising they're not going to injure themselves, and focusing on just small change, so just increasing some of their sedentary behaviour. So even if it's that they're walking up and down the stairs or they get dropped off 5 minutes from home and just walk that extra 5 minutes down the road. So starting with small, simple goals to essentially achieve weight loss. So educating on the role of cardiovascular disease and resistance exercise, learning about appropriate frequency, intensity, mode and duration of physical activity. She also talks about identifying barriers and goal setting similar to myself. And at the end of the day, providing feedback to the team.
So basically, we've realised and we've come to work together productively and successfully, that strong working relationships and team approach does come to successful outcomes for our patients. So I suppose we can just say, you know, if anybody out there wants to have a go at what we're doing, go for it, because the patients are just so happy and the results are really quite amazing. So together, basically, with the patients as the movers and us as the shakers, the Diabetes Clinic is a great success and rewarding results and happiness all round, really, and happy patients. So that's it.
Any questions at all?
Yeah, we got 2, 3, 4. You have to help.
I'd just like to find out the billing structure you would use, because if we did a care plan for 721 or 723 and then a TCA, we would then refer the patient on, or the doctor would refer the patient on for podiatry and dietitian and that. So how do you get around that to see everyone in one day? Could you tell me? Thank you.
So basically we don't do the care plan on the same day as doing the allied health visit. So the patient might come in and see the GP, I might do the care plan, and then I'll book them in the following week, to see me and the girls, and then I give them their machine, and we talk about how to use the BGL machine, and then they'll go on and see the girls, for their first session. The other thing is that for diabetes type 2 patients, there's also an allied health group referral that you can do. So either the dietitian or the exercise physiologist has the first visit, and normally the girls work that out. So that actually entitles the patient up to 8 extra sessions in a group scenario with allied health. Yep.
I wonder if you could explain a little bit where you might see the role of the diabetic educator fitting into this, because at my practice we've just got a new doctor and his partner, and the partner's a diabetic educator, so that's pretty handy.
So basically, just to give you a little bit of more background about myself, I'm almost qualified. I've got a month to go before I become a diabetes educator myself. So for me, obviously I'm going to have to work out what I do, whether I step back from being the practice nurse and being as active as I've been in managing diabetes, and whether I say, okay, do I just become a diabetes educator and not worry about doing that for the clinic, or do I go ahead and do that? If that's the case, then obviously, we've only got 5 visits that we can allocate to allied health. So again, we're going to be limited. So I don't know. We haven't discussed it in detail yet in the clinic, how we're going to approach it. But basically my role is almost similar to the diabetes educator, except that I don't do anything with insulin at this stage.
Thank you. But if you're referring them to the diabetic educator, that cuts down the number of visits they could have to the EP and the dietitian.
And again, I suppose it would depend on the patient's needs. So if the patient needs to go and see the diabetes educator, and again, that's up to the GP to decide, then the GP may say, oh, well, no, we need to send the patient to see the diabetes educator for 3 sessions, 1 session to the podiatrist, 1 session to the exercise physiologist. Yep.
Do I have to stand up? No, that's right. Can I just add to that? My name's Clare and I work for General Practice Services Victoria as part of a Medicare local, and we actually provide diabetic nurse-led clinics in the practice, and it only interacts with your allied health numbers if the actual diabetic educator uses their provider number. So a credentialed diabetic educator, which you will become very soon.
That's right.
Well done.
Exactly. Thank you.
When they use their provider number, it's put under the allied health. If they don't use their provider number, you can actually put it towards your PNIP hours. So it doesn't interact, it doesn't detract from their allied health 5 sessions that they can get.
Yeah. No, thank you.
First of all, I'd like to say congratulations. It's fabulous diabetes clinic, so well done, ladies.
Thank you.
Most of my questions have been answered. I was just wondering how you manage now, though, those really complex diabetic patients that do need more than 5 visits and need something different other than group. Do they pay themselves for your services, or how do they go?
Yeah, I've found a lot of them will continue visits if necessary. So we just charge very similar to what the bulk bill, like at the clinic we bulk bill, and we just continue about $50 for any following session, which is rebatable by private health if these patients do have private health. But I find most of them are happy to continue. Because they are in the clinic and they see myself and Nicole and Lisa and they're all there, they enjoy the team environment, they're very motivated to want to keep seeing change. So that motivation keeps them, even if it's a little bit out of pocket, to get them through that end of the year until they can get another care plan generated. They're all happy to do it. And some patients will then, I found we do the group sessions. So I do 4 sessions, the exercise physiologist does 4 sessions in a group setting, which can be anywhere from 4 to 6 people in the group. And then following, we can use their care plan visits to see them and go through a little bit more in depth one-on-one if need be as well. So that's another way around it, I suppose. Yeah.
That might be all the time we've got, sorry, just out of respect
Yep.
to the other speakers. Is that all right? Can you write your question down and
We can
see these
come see us
people?
after.
That'd be great.
Thank you very much.